I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the January 2017 edition of the PRS Journal Club podcast. I'm Jordan Frey, PRS Resident Ambassador from NYU. I'm here joined by my co-ambassadors Chad Purnell from Northwestern and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Maurice Nahabedian, Professor of Plastic Surgery at Georgetown University. Thank you very much, Dr. Nahabedian, for joining us for this PRS Journal Club podcast.
Oh, it's my pleasure.
So the article we'll be discussing now is Risk Factor Analysis for Capsular Contracture, Malposition, and Late Seroma in subjects receiving Natrelle 410 form-stable silicone breast implants. This is by Dr. Patricia McGuire, Dr. Neil Reisman, and Diane Murphy from St. Louis. And as a quick reminder to everyone, all of these articles that we'll discuss here, as well as past Journal Club articles, are available for free on prsjournal.com. So to begin, this article analyzes risk factors for the occurrence of contracture, malposition, and late seroma with the Natrelle 410 implants in over 17,500 subjects, and they collected this using two 10-year prospective multi-center studies. And as backdrop, the Natrelle 410 breast implants are teardrop-shaped, textured, and composed of highly cohesive silicone gel, with the texture designed to limit mobility and reduce malposition. They had a previous 10-year study where satisfaction with these implants was shown to be greater than 87%, the main indications being breast augmentation, primary breast reconstruction, and then revision procedures both for augmentation and reconstruction. However, capsular contracture, malposition, and late seroma are common causes of revisional procedures, so they wanted to look at these outcomes, specifically being that late seroma has not been described with these implants. Subjects came from the two studies previously mentioned. They're both 10-year prospective studies, and they broke up outcomes for four groups: augmentation group, revision augmentation, reconstruction, and then revision reconstruction. And they had over 5,000 augmentation cases, over 2,500 revision augmentation cases, 7,500 reconstruction cases, and almost 2,500 revision reconstructions, with a total of almost 32,000 devices implanted. They looked in the types of devices and the differences in device projection and also how the devices were placed in all the groups. And the results were not surprising in that there were more full or extra full projection devices in the reconstruction cohort, that the majority of devices were implanted using a partial submuscular placement, more so in the primary augmentation groups, and then complete submuscular placement was the next most common, and the majority of cases used antibiotic pocket irrigation. So the first outcome they looked at was capsular contracture, which they found at about 2% in the augmentation cohort, 4% in the revision augmentation, 3% in reconstruction, and 4% in revision reconstruction. And they ended up finding, in terms of risk factors, that with the primary augmentation group, these risk factors were subglandular placement, periareolar incision, and older device age, where in the revision augmentation group, it was older patient age that was a risk factor, and in the reconstruction group, it was higher BMI and no beta pocket irrigation, and there were no risk factors in the revision reconstruction group. They next looked at malposition. They found this less common. It was 1.5% in the primary augmentation cohort, 2.7% in the revision augmentation cohort, about 1.7 in the primary reconstruction group, and 2.7 in the revision reconstruction group. And this was associated with longer incision length in the primary augmentation group and capsulectomy at the time of implantation in the reconstruction group. And in both of the revision groups for augmentation and reconstruction, there were higher rates when the implants were placed in a physician's office versus an operating room. And the last outcome that they looked at was late seroma, which was defined as that identified greater than a year after implantation. And overall, this occurred in 0.1% of implants that were placed, with 0.06% in the primary augmentation group, 0.15% in the revision augmentation group, 0.06 in the primary reconstruction group, and 0.22 in the revision reconstruction cohort. And risk factor analysis they weren't able to perform due to these low numbers, but they do note that they were all found in patients who had submuscular placement of the implant. And they do make special note, although it wasn't a specific outcome they were looking at, that they found 4 instances of alcl, which is obviously a very important entity in any sort of implant case. And they had 1 reported in each group, and the range of years to diagnosis of alcl would range from 3.5 to 11.6 years. So in conclusion, they state that this data reaffirms the safety of the Natrelle 410 implants and that knowledge of the risk factors that they identify for capsular contracture and implant malposition can help offer guidance for reducing complications and optimizing outcomes. So in looking at this paper, I think they do a good job of accomplishing their goals of identifying these risk factors, which are all obviously important to know, and these, well, some had previously been defined. They hadn't been done so in such a comprehensive manner. But reading it, Dr. Nahabedian, I'd be interested to hear what you think, and then a few questions that just came up as I was reading it.
I think this is actually a very good article. I think it's comprehensive. I think they do a nice job evaluating the important outcomes that we wanted to measure with capsular contractures and late seromas and malposition, because I think these are probably the 3 most concerning elements when you use a shaped textured implant. And I think that it confirms that the incidence of these adverse events is very low, both in the augmentation cohort and in the reconstruction cohorts. So I think that the bottom line message is that these devices are safe and effective, and that people shouldn't really have concerns about using them for augmentation and reconstruction. Now, I'm a big advocate of using shaped implants for reconstruction just because I think that these devices really hold up well with the forces that are involved in the reconstruction patient. So these devices are doing 95% of the work when it comes to breast shaping. And I think that shaped, highly cohesive gel is better able to withstand some of the contractile forces of the skin over time. So I'm a big advocate of using the 410.
Is there a patient, say that you're going to do an augmentation, that you think is a good candidate in particular for style 410s, or specific instances where you like using those in the augmentation group?
Most of the augmentations that I perform are with round smooth shell devices. But I think there are a small subset of patients that I think would benefit. And I think it's mostly situations where you're really trying to modify the shape of the breast rather than modify the volume of the breast. So if somebody comes in and they may have perhaps a little bit of a tuberous component, or maybe they have some pseudotosis and they've got some scalloping in the upper pole where I want the device to give me a little bit more upper pole fullness, then I would consider using a shaped implant in somebody like that, or even a taller patient who's got a longer torso and I really want to create a little bit more upper pole fullness. I tend to use more of the medium projection, medium height devices in these patients rather than the full height or extra projecting devices. I just think there's too much parenchymal compression if you put in these highly form stable devices. So I tend to use something that's not quite as projecting because they're for augmentation, not reconstruction. In the reconstruction cohort, it's just the opposite. I use more of the extra projecting devices.
Those are great tips to hear. Looking at the specific outcomes that they evaluated, being malposition, capsular contracture, and late seroma, do you have any tips or tricks intraoperatively when you are using these textured shape implants to minimize the risk of malposition or malrotation?
The key thing with avoiding malposition with shape devices is that you really have to control the pocket. So you have to create a hand and glove fit. So if you're doing a primary augmentation, you don't want to over dissect your pocket. You actually want to leave it a little bit tapered at the apex superiorly so that the apex of the device almost kind of fits into a sleeve, so it's kind of a rigid construct. If you're doing a reconstruction and you're using a shaped implant, then my advice is to really, again, control the pocket. If you have to do a capsulorrhaphy inferiorly, if you have to do it laterally, then you really need to do it. And again, the important thing is to avoid over-dissection or over-capsulotomies in the upper pole, because you don't want to allow too much, lateral or medial movement of the superior aspect. So you really want to limit how much undermining you do superiorly. You really want that hand and glove fit.
For articles such as this that really look at risk factors for something, that we do commonly or people might be thinking of doing more commonly, especially from somebody who has a lot of experience with these kinds of procedures. How does this paper impact the way you practice? How does it impact the way you counsel patients? Or does this change anything? Or does this really kind of affirm how you've already practiced and what you already tell your patients?
Yeah, this actually gives me new information because I think the strength of this paper is a huge number of patients. They put in over 30,000 devices in over 17,000 patients. So they looked at capsular contracture and found that the incidence was really between 2 and 4%, and that malposition occurs in about 1 to 3%, and that late seroma, which is really important, is in less than 1%. And late seroma has been getting a lot of attention these days, but the fact that they've looked at these patients and tracked them for as long as they have, demonstrating late seroma rates, I think is important. So these are all things that I will certainly counsel patients about. The other piece of information that came out of this paper were the 4 ALCLs that they had. So they put in over 30,000 devices, and they had 4 cases of ALCL. So, the risk isn't zero, but the risk is very rare. I mean, even with these numbers, it's probably 1 in 8 or 9,000 patients that might be at risk. I personally have not seen an ALCL patient, and I've been doing primary reconstruction and augmentation for almost 22 years. So this is good information and certainly material that I will relay to patients.
Yeah, I think that's great, especially as ALCL becomes a hot topic and it seems like people are talking about it more. It's kind of good to have this data that shows that it's not very common, or at least good statistical evidence that it's not very common, in case patients ask about it, and I'm sure they'll start asking about it more.
Right. The nice thing about this is we know the numerator and the denominator, so it's a little bit more exact. I think with some of the information out there now, we know the number of patients, but we're still lacking a real true denominator. But this is very good information that is conveyed in this paper.
One thing that I wanted to know was that whenever the authors looked at risk factors for capsular contracture in augmentation patients, they noted that subglandular placement of the implant and a periareolar approach were both risk factors for capsular contracture, and this really isn't the first time that these have been brought up as concerning for risk of capsular contracture. So given that this article is showing this and it's been suggested before, are there still patients that you recommend these techniques for, or are you recommending them less and less?
Honestly, most of my augmentation patients are placed in the partial submuscular plane with a dual one or two, and I tend to use an inframammary incision. That said, there are situations where a periareolar incision may be considered and prepectoral device placement may be considered. So if a patient comes to me who's real athletic and I have concerns about putting a device under the muscle and they don't want something under the muscle, then I will still go in that prepectoral position. If somebody comes with a realar diameter that's large and you can easily access, I will consider a periareolar, but I have to say it's not my first choice. The other thing to keep in mind is, some of the studies that have been done over the years have really demonstrated higher capsular contracture rates with prepectoral positioning and higher capsular contracture rates with periareolar, but there is some ambiguity. There are mixed studies. There are other studies that show higher capsular contracture rates with inframammary incision. So I think a lot of it is technique dependent and, what precautions the surgeon takes in terms of using nipple shields and no-touch techniques and intraoperative irrigation protocols. So I think all of these play a factor and a role in development of capsular contracture. It's not only, a periareolar incision or a prepectoral placement.
Another last question. We've mentioned late seroma and also ALCL, which are becoming more and more hot topics. What has your experience been with late seroma, and how often have you observed it personally? Is it always with textured implants that you've seen it?
That's another good question. Late seromas are really not that common. There isn't a patient that really comes to mind that's had a seroma that's occurred over a year out that I've seen. Now, I know that that's not the norm because many surgeons have seen late seromas. I think that the key point here is that if you do see a late seroma, a year out, then you should go through the proper channels and have that analyzed, have cytology, and all the markers for ALCL need to be evaluated and ruled out. That's, I think, the important message. But again, like this study with an incidence of less than 1%, I don't recall off the top of my head if I've had a late seroma.
Yeah, not very common. With that, I think we'll end our discussion of this article. For everyone, remember to tune in to the other 2 articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcast every month. Also, don't forget to participate in our monthly Twitter, #PRS Journal Club, where we'll be able to interact directly with this month's selected article's authors, asking questions and discussing their article. And lastly, thank you again, Dr. Nahabedian, for so much for joining us and discussing this great article.